Hello everyone, my name is Rose Pignataro, and it is my pleasure to be able to speak with you about the role of physical therapists in tobacco cessation. Just as a little background information about me, I've been a physical therapist for about 28 years. I have a transitional doctorate in physical therapy and a PhD in public health. The PhD in public health is how I became interested in tobacco cessation interventions. I'm also a certified health education specialist and a tobacco treatment specialist. Just as an overview, I'm hoping that this recorded lecture will provide you with background knowledge that will allow us to have a dialogue, which is based on case studies, which will allow us to practice these counseling skills within the context of the types of circumstances we encounter when working with patients. The case studies are designed based on patients' readiness to change and common obstacles or barriers that they encounter when trying to quit using tobacco. So the formal objectives of this lecture are to establish a strong rationale for tobacco cessation counseling as a component of the physical therapy plan of care. It's important for us to recognize that tobacco cessation counseling within the context of physical therapy practice is not a standalone intervention, so no one's suggesting that you drop all of the other priorities in terms of rehabilitation and focus only on the tobacco cessation, but rather that we use the guidelines that we'll be discussing as a foundation for a component of patient education that can potentially affect the outcomes of the physical therapy treatment as well as the patient's future wellness. We'll be doing this by applying evidence-based guidelines for brief tobacco cessation counseling. These guidelines come from the United States Public Health Service and were tailored for physical therapists based on the general guidelines for healthcare practitioners. We'll then identify barriers towards the implementation of tobacco cessation counseling within the clinical environment so that we can discuss strategies to address these barriers. So as a disclosure, I do not have any relevant financial or commercial issues to tell you about, but I do want to acknowledge the Florida Physical Therapy Association for providing funding that helps support the development of this course material. Most of us are well aware of the negative impact of smoking and tobacco use on our health. However, just to provide some relevance for our discussion, let's review some of the epidemiological data. First of all, smoking kills approximately 14,000 people every single day. It is the leading cause of preventable premature mortality and disability. More than 480,000 deaths annually are a result of tobacco, be it primary or secondary, secondhand smoke. It is a leading cause of preventable medical expenditure. Approximately $300 billion a year are spent treating or addressing issues that are due to tobacco use. The statistic perhaps that has hit me the hardest is looking at the data from populations of people who continue to use tobacco throughout their lifespan. Up to 50% of current smokers will die of a smoking-related disease unless they're successful in quitting. On average, there's a 10-year reduction in life expectancy for people that use tobacco in comparison with their non-smoking peers. There's an absence of statistics reflecting the combined effects of other forms of tobacco use. So sometimes people smoke, but they also use smokeless tobacco or chew, or they may use smokeless tobacco or chew and also electronic cigarettes or hookah, some of the alternative forms of tobacco use that we'll be discussing as we go along. So as I mentioned, about 443,000 deaths each year are attributable to cigarette smoking. And if you look at the breakdown, there's things that are at the forefront of our awareness, things like lung cancer and ischemic heart disease that constitute a large number of people that are experiencing premature mortality and disability as a result of tobacco use. But we also have to think about the link to other forms of cancer, to stroke, other diagnoses, and chronic obstructive pulmonary disease. As a mortality risk, tobacco kills more people worldwide than HIV, tuberculosis, and malaria combined. So what supports the rationale for tobacco cessation counseling within the physical therapy plan of care? What compels us to want to include this as part of our interventions? First of all, if we look at the mission and vision for the American Physical Therapy Association, We see that we strive to transform society by optimizing movement to improve the human experience. So this provides our framework. When we're discussing any type of intervention, we should be thinking about our outcomes with regards to prevention, so the human experience as a whole, population health in transforming society, and the impact of whatever it is that we're addressing on the patient's movement and activities of daily living and ability to engage in their usual roles, whether it be their roles within the family, within the community, or their occupation. Tobacco use will affect each of these, as we will discuss as we move forward. So thinking about tobacco use as a future physical therapist, how do you think tobacco use would affect mobility and function, and how would it affect overall quality of life? The other thing that we want to contemplate is our role as healthcare practitioners, specifically as physical therapists. More and more, it's becoming more common for physical therapists to be involved in what's called primary prevention. So looking at ways that we can improve our current and future health so that we limit the effects of disability and we prevent premature mortality. Encouraging our patients to quit using tobacco has been shown to be one of the most important and cost-effective things we can do to promote health and prolong our patients' lives. It also works to improve outcomes, immediate outcomes, with regard to the reason why this person might be seeking physical therapy treatment. Tobacco cessation has a strong impact on both primary and secondary outcomes across all practice patterns. So if you think about the areas where physical therapists work, it really spans each of these. And it's pretty easy for me, as someone who's practiced primarily in cardiovascular, pulmonary, and integumentary health, to see how tobacco use might affect the working of the heart and lungs, healing for patients with open wounds. But now think about tissue healing in general and the ways in which tobacco use can prolong injury, not only to the skin or the cardiopulmonary and vascular system, but also to muscles, to nerves. So now we're talking about the effects of tobacco use not only in the cardiovascular and pulmonary area, but also in musculoskeletal health and neuromuscular health. The other thing is that physical therapists as a whole are very cost effective in the types of things that we might do when working with patients. So we play a very important role in terms of cost containment, especially as the escalating costs associated with healthcare becomes such a primary issue within our society. The last thing I want you to consider is the compatibility of tobacco cessation counseling with our expertise as physical therapists and the types of practice methods we use in the clinical environment. Patient education is the hallmark of physical therapy interventions. We do various forms of patient education, right down from the type of pathology that the person might have, in ways that they might modify their activity in order to speed their recovery, postural modifications, body mechanics, etc. So patient education is something that we excel at. We're just focusing our strategy for patient education in a way that promotes the likelihood of quitting tobacco. Because of repeated contact with our patients and the personal nature of what we do, we tend to build strong rapport with the people that we work with. That will assist us in helping them to quit tobacco. And then we also know that physical therapists tend to tailor their interventions to suit the individual, meaning that we may have general types of treatment strategies that we use per diagnosis, but we're always changing those to best suit the patient themselves. So that's true of tobacco cessation counseling as well. We know that it can be challenging for anybody to quit using tobacco, but the types of barriers that each individual faces will be different based on their circumstances and situation in life. There is a strong need for improved tobacco cessation interventions as we look at today's healthcare arena. Nearly 16% of all American adults use tobacco, so that accounts for approximately 36.5 million people. The percentage of use, the prevalence of use for tobacco will vary depending on what part of the country that you're in. So this takes into account different forms of tobacco, not only cigarettes. The prevalence of smokeless tobacco use is 9.1 to 1.3%, again, depending on where you are in the country. Among athletes, so if you're somebody that's involved in sports medicine, you may see a higher prevalence of smokeless tobacco use from 11 to 12%. Another big message for us to consider is that most people that smoke are, first of all, well aware of the general health effects, things like heart disease and chronic obstructive pulmonary disease, lung problems. But the other thing is that most people that use tobacco will also want to quit. So in a study conducted by the Centers for Disease Control, they found that 7 out of 10 people surveyed wanted to quit. In another research study conducted by the Miller School of Public Health at Miami University, 97% of the people questioned wanted to quit. So that means that for us, sometimes we're hesitant to approach the subject of personal behaviors with our patients, and tobacco use can be a really sensitive subject. If we know that the patient wants to quit and they're likely to be receptive to our attempts to assist them, then it becomes a little bit easier for us to talk about. There's been a change in demographics when we look at tobacco use as a whole. Overall, thank God, there's been a decline in rates. So there's less and less people that are using tobacco, so that's great news. The negative aspect of that is that when we look at the remaining users, if they could have quit on their own unassisted, they probably would have by this point. So the remaining people that are using tobacco are probably people that are heavily dependent and have significant barriers to cessation. These are the people that need our help the most. 40 million Americans are tobacco dependent, and this takes into account both combustibles, things like electronic cigarettes and traditional cigarettes, but also smokeless tobacco. This means that there's a lot of opportunities for physical therapists to improve access to tobacco cessation counseling. Only 17% of physical therapists surveyed included tobacco screening and counseling as standard practice. So this is an older study, about 13 years ago, and looked at physical therapists in 3 states, California, Tennessee, and New York, and asked them whether or not, number one, they included an assessment of tobacco use as part of their initial assessment. So I think we're getting better at this. We do ask people if they smoke. We don't always ask them if they use tobacco in general, which is important because somebody that uses smokeless tobacco will say no when you ask them if they smoke. If you ask them if they use tobacco, then they may tell you they don't smoke, but they do use chew. That's important to know. A more recent study that was done while I was at Florida Gulf Coast University here in Fort Myers was that only 30% of physical therapists that were surveyed within Florida provided tobacco cessation counseling. But more than 90% of them were unfamiliar with the clinical practice guidelines. So it's my hope that by doing this type of training, you'll become more familiar with these evidence-based guidelines so that you are able to select and choose when to apply them in clinical practice. Another study looked at whether or not smokers received cessation advice during their annual visit with a physician, and almost 80% of people did not receive that type of advice. There's various reasons for this. One is that physicians are, like physical therapists, are not as familiar with these clinical practice guidelines and may be hesitant to approach the subject with their patients. The other is time constraints, and we'll talk about why that's a barrier. We have a little bit of an advantage as far as time constraints because we see patients more than once over a short period of time. One of the most compelling reasons for physical therapists to become involved in tobacco cessation is that people with disabilities are more likely to use tobacco. And so this is derived from cross-sectional data. It's hard to draw a cause and effect from that. We don't know if people that use tobacco are more likely to become disabled because of the health effects, or if perhaps people with disabilities are more likely to smoke because of the use of tobacco as a coping method to help deal with stress, or it could be a combination of both. So if you look at this diagram, it compares people with disabilities to their non-disabled peers, and you will see that there is a much greater likelihood of tobacco use among the people with disabilities. They also tend to use tobacco at higher intensities. So looking at the epidemiologic data that was shown in the previous graph, people with disabilities are 50% more likely to use tobacco. They're also less likely to receive counseling. So if you think about the amount of time someone with a disability has contact with a healthcare provider, it's probably much higher than the general population. But the likelihood of them receiving tobacco cessation counseling is actually much lower. So think about the reasons why that might be true. Some of the reasons might be that when they see a healthcare provider, that healthcare provider's primary focus is on the disability itself. So managing that disability, making sure that the person gets the proper tests, interpreting those test results, and changing their treatment plan in terms of immediate outcomes. They're less likely to spend time and apply thought in terms of health promotion, preventing future issues, and that's where physical therapists really come in. The other reason to target people with disabilities is that they experience the clustering of other behavioral risk factors. Besides a higher prevalence of tobacco use, they also have a higher prevalence of sedentary lifestyle, so they're less likely to get regular physical activity or exercise. They're also subject to improper nutrition. They experience challenges related to stress and coping, challenges related to getting proper sleep, and reduced access in general to health care. The next thing that we'll be talking about are alternative forms of tobacco use. And the reason that I've included this is that most of the population and most physical therapists are most familiar with the adverse health effects of using cigarettes. But that's not our only problem, so let's think about this. Alternative forms of tobacco use will be an issue depending on which segment of the population you're working with. So if you're working with a younger demographic, patients that are college age or even younger than that, sometimes the forms of tobacco use you'll see are not necessarily traditional cigarettes, but things like the water pipe, also called hookah or shisha. A single session of hookah can produce toxin levels that are equivalent to 50 cigarettes. Most people have no idea. If you ask a college student or a young adult about hookah in relation to cigarette smoke, often they perceive that it's less harmful. First of all, they're not doing it on a regular basis. It's not an everyday thing. It has more of a social context. And because they're sharing or passing the pipe, they think that they're not using it at as high of an intensity if they were to have a cigarette by themselves. The problem with this is that a hookah pipe can have 1.7 times the level of nicotine in comparison to a traditional cigarette. The other thing is that hookah is not regulated. The tobacco that's used in a hookah pipe is not regulated by the FDA. And it's not standardized, so we really have no idea what other types of chemicals are in there as far as flavoring or toxins, or whether or not it's delivering a standard dose of nicotine. We have a rough idea of how much nicotine is in a traditional cigarette, but this can vary depending on the type of tobacco that's being used in the water pipe. It can have 3 times the amount of carboxyhemoglobin, so now we're talking about carbon monoxide, and its impact on the capacity for the blood to carry oxygen to the tissues, and also the amount of tar. So the risks associated with water pipe use include nicotine addiction, cancer, heart disease, secondhand smoke exposure, and also infectious diseases from sharing that mouthpiece. It may also act as a gateway to cigarette smoking or other tobacco use because of the nicotine. We know that nicotine rapidly crosses the blood-brain barrier, which makes it as addictive, if not more addictive, than things like cocaine. It's very serious substances. And I mentioned how there is a lack of federal regulations or standards for manufacturing. The dangers: hookah use is popular in social situations, so not only feeling like you're associating the hookah with enjoyment and socialization, but also perhaps peer pressure. The risk perception also contributes to higher use because it's perceived to be less harmful than cigarettes. People that use hookah are less likely to label themselves as smokers because of the pattern of intermittent use. It's more common on weekends, or I don't know about out in Montana, but here in Florida, Thursday night is the big night to go out. So it's more common on Thursday nights. And longer average sessions. If you're smoking a cigarette, you're doing it for a few minutes, maybe every few hours. If you are using a water pipe, then sometimes the session can last as long as an hour, even though it's one single session. Hookah can attract alternate users, people that would not normally pick up a cigarette because of its aromatic smell and the flavors that are involved, and because of that social interaction. Acute effects of hookah use include increases in systolic and diastolic blood pressure, heart rate, and respiratory rate. So we also need to consider the timing of use and the level of physical activity for the person that is participating in the water pipe session. It has a negative impact on lung function with reductions in vital capacity as compared to cigarette smoking. So it can actually have a higher impact on lung function than traditional cigarettes. And it has been associated with lung cancer despite this lower risk perception. The odds of developing lung cancer associated with water pipe use is 2.12. So that means that you might be 2 times more likely to develop lung cancer as compared to people that don't use a water pipe. Smokeless tobacco is another form of alternative use that we should consider. I mentioned before how there are higher rates of smokeless tobacco use among athletes, not only professional athletes, but amateur athletes, college athletes as well. The forms of smokeless tobacco include moist snuff, dry snuff, and something called snus. I don't know if you've seen this. It's not really popular here in Florida, but when I went to grad school in West Virginia, this was a really big thing. Snus almost looks like a tiny little tea bag, and if you look across the illustrations on the bottom of the slide, it's the one furthest to the right. So this little tea bag type of material is placed between the lip and the gum, and it reduces the need to spit. So it's often hard to tell if somebody's using snus, and it may be more popular in certain settings because you don't need to be spitting out the juice from the tobacco. The bad part of this is that people are swallowing that juice and it acts as an irritant potential toxin for the GI system. Again, like hookah, smokeless tobacco is commonly viewed as being less harmful than cigarettes. The other thing is that because you can't tell if somebody's using smokeless tobacco, it gets around those restrictions, the clean air policies, the indoor smoking policies. Dissolvable products are another form of alternative tobacco use that we would want to consider. These are forms of tobacco that are then shaped into pellets, sticks, or strips and combined with flavoring. The most harmful thing about these products is its appeal to a younger demographic. So for marketing purposes, I'm sure the tobacco industry loves this because they're inducting new users from that younger demographic, getting them hooked on nicotine and ensuring that they have a future market share. The dangerous part of this is that obviously the younger someone is, when they start to use tobacco products, then the higher the potential for long range impact. So some of the risks that are associated with these various forms of smokeless tobacco use are that they carry high levels of carcinogenic nitrosamines, and they can cause nicotine poisoning. I had never seen nicotine poisoning before until I was in grad school. And when I was in grad school, I used to volunteer at student health. And sometimes we would see people come in on a Friday morning, typically because of the high prevalence of water pipe use and other social forms of tobacco use on Thursday evening. And these people would come in with these crazy symptoms: vomiting, sweating, mental confusion, a decrease in pulse rate, so they would be bradycardic. They might have a headache or difficulty breathing, all because of the amount of nicotine that they had taken in, whether it be from some of these dissolvable products, the chew, or multiple forms of tobacco use, chew in combination with the hookah or an e-cigarette, etc. People with nicotine poisoning will also present with difficulty breathing. They can go into respiratory failure due to muscle paralysis, and the biggest issue is that there is an impaired transport of oxygen due to elevated levels of the carboxyl hemoglobin. E-cigarettes have become a really big issue, both in New York and in Florida. Again, I don't really know about Montana. You guys will have to tell me more about that during our live session. The problem with e-cigarettes is that they are often marketed as safer alternatives to traditional cigarettes and are sometimes perceived as an aid to cessation. Now, can it help someone quit? I guess theoretically it might. But it's not the same as using a nicotine patch where there's a very regulated dose that allows us to progressively decrease the amount of nicotine that the person has. One of the biggest issues is that depending on the brand of e-cigarette and the type of fluid that's being put into the electronic cigarette, like the hookah, we don't know how much nicotine is actually present. So to be able to taper that dose while the person is undergoing treatment for cessation is very difficult. 12% of people that use e-cigarettes actually become dual users, meaning that they're vaping, and in addition to vaping, they continue to smoke regular cigarettes or they continue to use chew, etc. E-cigarettes still have nicotine, and I think there are a few that only have flavoring, but mostly the purpose is as a nicotine delivery system, and nicotine itself carries associated health risks, especially in terms of tissue repair, which is something that we would be concerned with as a physical therapist. According to the American Journal of Public Health, unsubstantiated, overt, and implied claims that alternative tobacco products aid in smoking cessation should be prohibited. And the reason that they should be prohibited is that this is not at all supported by the research. So what are the benefits of tobacco cessation? What are some of the potential payoffs for this? Incentives for us to become involved in it as physical therapists, but also incentives for our patients. There are immediate health benefits of tobacco cessation. Within the first 2 weeks to 3 months, your patient will experience an improvement in blood flow and improved cardiovascular endurance. Their lung function can actually improve up to 30%. Within the first 1 to 9 months, the cilia in the lungs help start to regain their normal function, and coughing, fatigue, and shortness of breath decrease. Now, there is a little bit of a caveat here. I've had patients tell me, I stopped smoking and now I'm coughing more than ever. That's because they have all of these secretions, the retained secretions within their lungs, and now those secretions are being mobilized because they're no longer using tobacco. The cilia are beginning to function appropriately, and they're taking deeper breaths. They're able to use greater capacity within their lung fields. And so from the circulation of air and the combination of the cilia starting to work better, they're starting to move these secretions, and they may actually cough more and start to get this junk out of their lungs. That's a good thing. So when your patients tell you that they quit smoking and they're coughing more, that may be the reality, but it's short term. So the coughing is the body's way of trying to undo some of that damage. Within a year, the risk of heart disease in someone who quits smoking decreases by 50% as compared to somebody who continues to smoke. So this is a powerful message for people that have smoked a long time in particular. So sometimes we'll have patients tell us that they started smoking as a child. They started using tobacco in their early teens or even younger sometimes. And now they're in their 50s or 60s and they want to know what the benefit of cessation is when they've already done the damage. That's true to a certain extent. Yes, there will be some existing damage that may be permanent, but the future damage has been prevented, number one. And number two, over time, some of that past damage will start to decrease. Within 5 years, the risk of stroke for somebody that quits using tobacco is now the same as somebody who has never smoked. Within 10 years, lung cancer mortality rates are decreased by 50% as compared to people who, again, continue to smoke. And there are significant reductions in all other forms of cancer that are associated with tobacco use. After 15 years of cessation, the risk of heart disease for somebody who has successfully quit is the same as somebody who has never smoked. So if you do have somebody in their 40s or 50s, they've taken that 10-year reduction in life expectancy and reversed it after 15 years. They've basically added 10 years to their life. The benefits of cessation for people that use smokeless tobacco. Smokeless tobacco is associated with cancers of the lungs, the kidneys, the larynx, the bladder, the esophagus, pancreas, stomach, and cervix. So although the areas are different, smokeless tobacco is also, just like regular cigarettes, associated with an elevated risk of cancer. There's also an increased risk of leukemia, sinus cancer, liver cancer, breast cancer in people that use smokeless tobacco, and an increased risk of atherosclerosis, which is associated with the risk of stroke and peripheral vascular disease. Chewing tobacco is significantly associated with oral health risks. So if you look at these pictures, you can see some of these really horrifying effects of smokeless tobacco use. So aside from the effects that we just discussed, things like oral cancer and periodontal disease, tooth loss, and alteration of taste and smell are all consequences of smokeless tobacco use. So in terms of PT treatment outcomes, we've talked about the general health effects, but specific to the reason why the patient might be coming to see you as a physical therapist, what's the impact of tobacco use? Because when we counsel our patients, we want to make it relevant. If I'm coming to you with, say, a rotator cuff strain or a rotator cuff tear, and the first thing you do is start to talk about my tobacco use, I'm going to be turned off. That's not why I'm here. I'm here so that you can help me get my shoulder better. We need to be able to talk about tobacco use in reference to the reason why the patient is seeking our help. How does that tobacco use affect the outcomes for their shoulder rehabilitation? So let's look at the risk factors associated with nicotine in general. So not only cigarettes, but all of the other forms that we just discussed, the hookah, the electronic cigarettes, the smokeless tobacco. Each of those contains nicotine. And we said before that tobacco use crosses all practice patterns within physical therapy. We're aware of the cardiovascular and pulmonary risks and the integumentary risks, but we want to talk more about the musculoskeletal and neuromuscular risks. In general, tobacco use has pro-inflammatory influences. So very often as physical therapists, we think of inflammation as a negative thing. We need to recognize that some inflammation is good. It kickstarts the healing cascade. It allows the body to go into the proliferative phase where it's generating new cells and undergoing tissue repair, and then into the remodeling phase. So some inflammation is okay. Systemic inflammation or prolonged inflammation is not okay, and that is one of the ill effects of nicotine. Some of the research on tobacco use has shown that there's an increased level of inflammatory cytokines in people that use tobacco. There's also an impairment in mitochondrial function. So looking at the cellular level now, there's mutations in proteins which can generate tumor activity. There's impaired glycolysis, so the ability to break down and utilize glucose to drive cellular metabolism is impaired because of the nicotine. There's also impairments in lipid metabolism. This is particularly relevant when we look at tissues that have higher cellular metabolic rates, things like cardiac tissue, skeletal muscle, and the central nervous system. So as I mentioned before, the cardiovascular and pulmonary effects of tobacco use are well recognized. So if you look at marketing campaigns, social marketing, advertising, a lot of that will focus on the cardiopulmonary effects of tobacco use. Things like emphysema, lung cancer, asthma, ischemic heart disease, peripheral vascular disease. So many times these are things that our patients are well aware of coming into physical therapy. The musculoskeletal effects are usually something that most of us have not considered in great detail, and it is something that is particularly relevant to the reason why the person is probably seeking your assistance as a physical therapist. People who use tobacco have an increased risk of osteoarthritis as compared to people that don't use tobacco. They also have an increased risk of rheumatoid arthritis. This is thought to be secondary to interactions with the person's genotype and or the influence of nicotine on those inflammatory mediators. There's an increased risk of degenerative disc disease and back pain, and there's poor outcomes in delayed or incomplete healing with an elevated risk of disability in people with meniscal injuries, so knee pain as well. Tobacco use is associated with impaired muscle strength and endurance, and these these studies were done with young cohorts of people, young groups of young people, and in fact, some of them were done with people that are very well trained physically. Some of the studies come out of the military, looking at people in boot camp, people that are trained to work in the field, and whether or not there's any differences in muscle activity, endurance, and strength for people that use tobacco versus people that don't. And the impairments in muscle strength and endurance may be because of the impact of the nicotine on the mitochondria, as well as oxidative damage to the muscle proteins. For us as PTs, this affects our exercise prescription and the patient's response. From a physiological perspective, there are nicotinic receptors all over the central and peripheral nervous system. Nicotine mimics the effect of acetylcholine, so it works to activate the muscle. If the receptors for acetylcholine are blocked by nicotine, then there's less receptors available to participate in muscle activity. Excessive stimulation of those nicotinic receptors can lead to degeneration. And also, as I just mentioned, the competitive inhibition can reduce the muscle's ability to generate peak torque. Nicotine as a whole is a powerful vasoconstrictor, so it reduces blood flow and oxygen availability to the muscle during exercise and physical performance. Not only is it a powerful vasoconstrictor, but it causes an increase in concentration of carbon monoxide, which replaces the oxygen that would normally be carried by the hemoglobin within the red blood cells. Nicotine can also reduce testosterone levels. Testosterone deficiencies can interfere with the patient's ability to build muscle. So some of the research studies on tobacco use have found that there's decreased endurance of the spinal extensor muscles and the postural stabilizers when comparing smokers to non-smokers. In animal models, nicotine has also been observed to impair motor learning, even though it may initially enhance skill. So what this means is that sometimes when you're working with athletes, they may tell you that they use smokeless tobacco either right before or during a game because they perceive that it has a positive impact on their performance. And this may be true in the short term, so it's important not to deny that because it's consistent with their actual experience. We don't want to try to contradict that by saying, no, it's harmful, when the patient truly perceives that it has a benefit to short-term performance. Instead, we want to direct their attention to their long-term performance and their ability to recover from injuries. So for that short-term boost, now you're compromising your longevity within your sport, your ability to get better at what it is that you're doing. Nicotine in tobacco use has been associated with tendinopathy. People that smoke and use other forms of tobacco have higher incidence of rotator cuff tears, and this association is dose dependent. So people that use tobacco at higher intensities are even at greater risks. There's larger tears in people that use tobacco with greater risk of failure for surgical interventions. And it is also a risk factor for the rupture of the distal bicipital tendon. Once that tendon has been injured, nicotine continues to impair the ability to heal. There is fibroblast degeneration, irregular fiber deposition and organization for the collagen, and vascular insufficiency. Nicotine can contribute to insulin resistance. We know that the skeletal muscles are a primary metabolic site for glucose, and tobacco can reduce the muscle's capacity to transport and utilize these essential nutrients. Tobacco use also accelerates the normal, well, I don't want to say normal, but it's not really normal, but age-associated loss of muscle mass. It impairs, again, the muscle's metabolic abilities. It increases the inflammation and oxidative stress on the muscle, and it causes an upregulation of proteases, which contributes to muscle breakdown and atrophy. When they have done studies comparing older adults who use tobacco and those who don't, they found that the people that use tobacco have a higher incidence and severity of motor impairments as they continue on in the lifespan. This includes reductions in agility, coordination, and balance. There's an increased risk of osteoporosis in people that use tobacco, an increased rate of fractures and pathological fractures, and delayed union. This is because tobacco use contributes to a loss of bone mineral content and also to delayed healing in the bone. So when we look at the impact of tobacco use on the skeletal system, we can consider this from a number of physiological perspectives. First of all, tobacco reduces the amount of available estrogen. So in a way, it acts like an artificial menopause. And we know that postmenopausal women are more prone to osteoporosis and pathological fractures. It increases cortisol levels, which can accelerate the breakdown of bone. It inhibits the differentiation of osteoclasts. It interferes with the intestinal absorption of calcium, and it reduces the level of vitamin D. In general, we know that nicotine has a negative impact on circulation and blood supply. So in terms of skeletal healing, bone healing, the availability or lack of availability of adequate oxygen and nutrients can delay or prolong recovery, or sometimes result in incomplete recovery and the susceptibility to future injury. Neuromuscular effects. Tobacco use increases the risk of neurological impairments, things like CVA, dementia. It's been associated with a higher prevalence of Alzheimer's disease, ALS, or Lou Gehrig's disease, and multiple sclerosis. Looking at, again, those population studies in epidemiology, higher prevalence of chronic pain in people that use tobacco as compared with the general population. Amplified pain response with the decreased efficacy of opiate medications in people that are experiencing pain. It's thought that nicotine may lower the pain threshold in the central nervous system. And in general, there are greater functional deficits in tobacco users who have pain. So not only pain itself, but its impact on the patient's function and ability to recover. In terms of physical activity, there are negative associations between nicotine dependence and the level of physical activity. And again, just as a reminder, these are cross-sectional studies, so we have to be really careful about drawing conclusions about cause and effect. But in general, people that smoke exercise less than non-smokers. There are negative associations between smoking and endurance, so it could be that the people that smoke have to work harder, which deters them from exercising. Higher incidence of exercise-related injuries in people that use tobacco. So this particular study involved Army recruits during basic training and found a 40% incidence of injury in smokers versus 29% in non-smokers. And this is in the male cohort, even higher in the female cohort, 56% incidence of injuries, which is 10% higher than the non-smokers. Integumentary effects, so when we look at wound healing, once again, the effects of nicotine as a vasoconstrictor, impairing blood flow and oxygenation. This one study showed that nicotine can reduce cutaneous blood flow by as much as 40%, and that can last up to 2 hours. So say we have a patient that smokes one cigarette every 2 hours and they have an open wound. That means that this person is in a chronic state of hypoxia because just as the nicotine is beginning to wear off, they have another dose. It also contributes to something called repeated reperfusion injury, the accumulation of free radicals, etc., within the tissues that can contribute to secondary cellular death. It increases the risk of infection because it impairs the immune response and decreases the proliferation, viability, and function of the white blood cells. In terms of tissue repair and the types of research that have been done, tobacco use is associated with delayed wound closure and increased risk of re-injury. It stimulates the release of proteases, so instead of forming new tissue, it actually contributes to tissue breakdown. It impairs the migration of fibroblasts and wound contraction, and it reduces plasma levels of vitamin C, which is necessary for clotting and other stages of wound healing. So now that we've talked a little bit about the effects of tobacco, the adverse impact of tobacco in various areas of physical therapy practice, let's look at the actual techniques now that are involved in tobacco cessation counseling. These are based on principles of motivational interviewing, and from what I understand, you have some background in this. So we're going to be drawing on that past experience and using it to apply it to a specific situation involving the use of tobacco. Potential barriers, and some of this comes from research in other professions, and some of it comes from a study we did at Florida Gulf Coast University where we surveyed physical therapists within the state of Florida and asked them whether or not they were doing tobacco cessation counseling, and if they weren't, what was getting in their way. So some of the factors that we found that we need to consider are that there's time constraints, right? We really need to do a whole lot of things in a very short period of time, and that's becoming more and more of an issue as insurance reimbursement becomes more and more stringent or more and more limited. So looking at the barrier itself, time constraints, how do we address this? First of all, when we look at the clinical practice guidelines for healthcare practitioners, we're not talking about counseling in the traditional sense. So somebody like a psychologist or a psychiatrist might do counseling that involves a 45-minute one-on-one session that delves very deeply into the issues that the patient might be facing. That's not what we're talking about here. Brief counseling can take as little as 3 to 10 minutes, and that doesn't have to occur all at the same session. It can be broken up. So if I'm going to see somebody twice a week for 4 weeks, I have 8 opportunities to engage in a conversation around tobacco cessation with that particular individual. Also, the types of practice methods that are utilized by physical therapists are very conducive to successful tobacco cessation counseling. We can incorporate our advice into normal PT sessions. We don't need to set aside a specific amount of time. It's really just a component of the normal patient education that we would be doing as part of our attempt to promote independence and autonomy for our patient and to speed up their recovery with the things that they're doing on their own in between sessions. Anticipated patient resistance is another potential barrier. So as I mentioned before, we're addressing something that is a personal behavior, and often as physical therapists and other types of healthcare providers, we're hesitant to do this because we almost feel like we're going into an area that's really not our business. It is our business because, as we just saw, it can impact the patient's outcomes for physical therapy. Other factors for us to consider is that most patients want to quit, and they are receptive to the things that we tell them because they perceive us as having a certain level of expertise. Specific to tobacco cessation counseling, it actually has been linked to increased patient satisfaction with their health care, and this is independent of whether or not the person actually quits. When we talk to our patients about personal behaviors and the way that it impacts their overall health, they perceive us as being very caring and interested in them and their wellness as a whole. The other thing to consider is that motivational interviewing in general and specific to tobacco cessation, it is designed to work the best in patients that are initially resistant to change. Perceived lack of efficacy is another barrier. So we don't want to spend time doing something that is potentially not effective for our patients. So there's therapists and other healthcare providers that may look at tobacco cessation and say it's a waste of time. If the person wanted to quit, they would. As we saw from the previous research that we discussed, that's not always the case. 7 out of 10 people, or in the case of the study done at Miami University, almost 100% of the people, 99% of the people wanted to quit. People know it's bad for them, they want to quit, but they're unable to overcome the barriers. So motivational interviewing is designed to talk about those barriers in a productive way so that the patient themselves is identifying strategies that overcome those obstacles. About 40% of people that are counseled by a medical provider will make a cessation attempt. That's very encouraging. 40% of the time, what you're saying to the patient has a real impact on their behavior. The other thing is that think about the settings in which physical therapists work. We're working in acute care, we're working in inpatient rehabilitation. You can't smoke. You can't use tobacco in general in those types of settings. So when we're working with a patient for rehab, that patient's already been through a period of forced abstinence. So they've gone several days or in some cases several weeks without using tobacco. It's important to be able to build on that success, whether it was intentional or not. So that period of forced abstinence may actually increase their likelihood of long-term cessation. The other things to think about are our role within the healthcare arena. What's our professional obligation as physical therapists? First of all, over 10 years ago, the APT identified smoking cessation as an important component of health promotion. It's an important component of physical therapy patient education. It promotes effective self-management and enhances the patient's autonomy and functional capacity. The other thing to consider is that the expansion and evolution of our roles, particularly as we begin to act as entry portals for primary health care because of direct access. So in many instances, if you perceive that it's not your role as a physical therapist to counsel a patient to quit using tobacco, the thing to think about is that you may be the only healthcare provider that person is seeing. And you may be the only person that approaches the subject with them, so then it becomes even more important. Physical therapists are advocates for people with disabilities, and as we've seen, people with disabilities have a higher prevalence of tobacco use and less access to treatment. There's reduced efficacy of physical therapy interventions in people that continue to smoke. People that use tobacco, in comparison to the general population of physical therapy patients, tend to have longer episodes of care, and their results are suboptimal in terms of functional recovery. The other thing is that Joint Commission requires in acute care setting that tobacco cessation counseling be a component of care for any patients who are admitted from the community with an acute MI or community-acquired pneumonia. So as part of the interprofessional care team, physical therapists can help meet these accreditation criteria. Inadequate reimbursement is another barrier for tobacco cessation counseling. And not to be glib about it, but this one always strikes me a little bit funny. It's a little bit humorous to hear us complain about inadequate reimbursement as a barrier towards any type of intervention, because that's true for PT as a whole. Getting fair reimbursement is something that the American Physical Therapy Association strives for. It's a continual battle for us. So let that be an incentive for you to be active in your professional association, including the political action committees. It's how we have our voice in legislation and reimbursement. So in terms of inadequate reimbursement, some of the things for us to think about with reference to tobacco cessation is that tobacco cessation counseling is cost effective. So when we include it as a component of patient education, it helps enhance our outcomes. It reduces the overall number of visits and decreases the patient's chances of re-injury and needing future interventions with the PT. Practice-based outcomes research, so as we move along further in this field and start to gather data, we can use that data to advocate for fair reimbursement of these effective interventions. And there are also billing mechanisms for general patient education that can be also applied to tobacco cessation counseling. Lack of system support, this is a really big issue. So if you're working in an environment that is not receptive towards physical therapists being involved in tobacco cessation counseling, that could be a very big obstacle. So tobacco cessation counseling really requires the investment of the entire staff. Everybody has to be on board, from administration to the clinicians themselves to our support personnel. Support personnel can assist us by identifying patients that smoke. So when patients are in the waiting room and they're filling out their intake forms, if they use tobacco, if the person that's accepting those forms from the patient in preparation for their evaluation with the physical therapist flags that chart, the clinician then will be more aware of being able to integrate this in their plan of care. It's been recommended that administrators adopt policy that ensure that all tobacco users are first of all identified. And as I mentioned, physical therapists are usually pretty good at this. During our history, we ask patients if they use tobacco. Well, now we have to make sure that we're carrying that information forward in terms of the plan of care. Lack of training. This is a big issue because most physical therapists that we surveyed in Florida had no idea that there were even clinical practice guidelines for tobacco cessation counseling. However, when we pilot tested this training, what we found was that PT students had positive changes in knowledge, attitudes, and intention to apply the clinical practice guidelines following their training session. And when we modified the course as a continuing education unit for experienced physical therapists, we had the same results. That training should be reinforced by practice in clinical settings. So although we're talking about this in the classroom and practicing it using case studies, hopefully you'll use this experience moving forward with your clinical instructors and as future physical therapists to get the ball rolling, to make sure that this is something that we regularly do as PTs. So don't be silent about smoking. This comes from the Department of Health, but your patients trust you and they need your guidance. It's one of the most important things that we can do as PTs in terms of the patient's recovery and their future health. Let's consider some key facts about tobacco use. The biggest thing is for us to recognize that this is a chronic issue. It requires multiple interventions and multiple quit attempts, so it's unlikely that we counsel a person once and they become motivated to quit and they're successful the first try. Most smokers require at least 9 attempts for long-term cessation. And I mentioned before how quickly the nicotine crosses the blood-brain barrier, which makes the addiction comparable to the addiction to cocaine, amphetamines, and opiates. The good news is that advice from 2 or more healthcare providers can double the likelihood of successful cessation. So that means if we're delivering the message as physical therapists and the person also hears the same consistent message from the physician or the physician's assistant or the nurse practitioner, etc., it makes it even more likely that this person will be motivated and successful in their attempt to quit. So what is addiction? If we look at the textbook definition of it, it's engaging in a compulsive behavior even when faced with adverse consequences. So this fits tobacco use to a T. Nobody is using tobacco because they're unaware that it can damage their health. So whether or not it's specific to the reason why the patient is seeking physical therapy, most people are well aware, if not all people, that it can cause lung cancer, heart disease, etc. So why do you engage in the compulsive behavior? It's because there's been reinforcement or reward associated with the tobacco use. And there's some negative reinforcement as well. Patients fear withdrawal as a barrier to cessation. So the potential for withdrawal perpetuates the addiction. Eventually what happens is that the behavior interferes with ordinary day-to-day life, such as the person's health, occupation, and or interpersonal relationships. So the addiction becomes problematic because it interferes with the patient's values and goals. When we look specifically at addiction to nicotine, there are psychological aspects, behavioral aspects, and socio-cultural aspects. From a psychological perspective, there's definitely a sense of comfort that's associated with tobacco use. So it's very common for people to tell us that they use this as a stress or coping mechanism. And in the short term, that may be right. It does contribute to stress relief, more on an immediate basis. Long term, it's actually generating stress because if you become sick as a result of tobacco use, your income earning capacity is reduced. You're not really able to do any of your social or recreational activities, etc. So it alleviates stress in the short term, but generates stress in the long run. Behavioral aspects are that there is a learned anticipatory response to nicotine, so that immediate gratification reinforces the addiction. Sociocultural aspects are becoming less and less prominent now that there's more of a negative stigma associated with tobacco use. But the thing to consider is that while there's a negative stigma that's generally associated with cigarettes, there's not a negative stigma, and in fact, in some cases, there is positive peer pressure for tobacco use for things like electronic cigarettes, so vaping, and hookah use. So we have to think about sociocultural aspects from the population as a whole, but also from an individual's peer group, as well as other family members or a significant other. So people where other family members or a spouse smokes, they're really going to have some very significant challenges if they decide to quit. As I mentioned before, there are nicotinic receptors spread throughout the central nervous system. Within the brain itself, nicotine mimics the effects of acetylcholine. It interferes with the downregulation of acetylcholine production, and it activates excitatory pathways. So our athletes, when they tell us that this primes them for their sport, they have better performance. That might be true in the short term. When you're talking to students that use nicotine as a stimulant so that they can spend longer amounts of time studying and have reduced stress, well, there is a physiological basis for that, but we need to, again, focus more on those long-term effects. The physical aspects of nicotine addiction are that nicotine stimulates the release of things like dopamine, serotonin, norepinephrine, vasopressin, and beta endorphins. Dopamine induces feelings of pleasure. Serotonin reduces stress. Norepinephrine can act as an appetite suppressant. So we'll get to this in a little while, but another barrier to cessation is this fear of weight gain. Vasopressin can enhance short-term memory and short-term cognitive function, and beta endorphins can alleviate tension and anxiety. So there are some positive effects, some very real physiological effects of tobacco use that are seen as something beneficial by people that use it. The problems are that neuroadaptation occurs with chronic exposure to nicotine, and tolerance develops. What this means is that it takes greater and greater amounts of nicotine to induce the same rewarding effects. So the dose has to increase. The person progressively has to use more and more nicotine in order to gain the same benefit. Withdrawal then will develop because of impaired brain function in the absence of nicotine. There's been an upregulation in the number of nicotinic receptors in the brain, so it takes more and more nicotine in order to fill those receptors and gain the same pleasure. So here's an example of neuroadaptation. If you look at the frontal cortex of the non-smoker on the left as compared to the smoker, you see that people that smoke have an increased number of receptors. Factors that are involved in whether or not the person will develop a nicotine addiction are varied. One is the dose delivered, so how much nicotine is this person having, and the frequency of the dose. How often are they smoking, vaping, using chew? The mode of delivery, cigarettes are very, very efficient in delivering nicotine. That's because there's a very high rate of absorption at the level of the alveoli when the person inhales the smoke. So in general, cigarettes actually deliver the nicotine more efficiently and quicker than oral tobacco products such as chew. Nicotine can cross the blood-brain barrier in as little as 10 seconds. The route of absorption is through the lung epithelium and the oral and nasal mucosa, so that moist epithelium in the alveoli and in the oral cavity, but also through the skin. The lungs are actually the most efficient route of absorption because of the enormous surface area. So there's lots of space for diffusion of the nicotine across the alveolar membrane and into the patient's bloodstream. Symptoms of nicotine withdrawal: cravings, irritability, frustration, anger, anxiety, difficulty concentrating, increased appetite and weight gain, depression, mood disturbance, insomnia, and headaches. So all of these sound just awful, right? So you can see why somebody would be hesitant to want to voluntarily put themselves through this. However, part of the message that we need to be giving patients is that these are short-term. Typically, the symptoms of nicotine withdrawal, regardless of how long the person has smoked, tends to peak within a week of cessation. As a whole, it only lasts about 3 to 4 weeks. These are the physiological effects. Remember that there are behavioral impacts and sociocultural impacts that we also have to take into account. So how do we assess tobacco use? The first step is basically just to ask the person, do you use tobacco? And remember that that is the favored approach to this, not do you smoke, because the person may say no and still use something like chew or one of those dissolvable products. So when we talk about assessing tobacco use, it's first of all, does the person use a tobacco product? But also we want to get more information about the dose, whether or not they're addicted to nicotine, and what's their readiness to change. So smoking and tobacco history, this should really say, because we just talked about it not only being combustibles, things like traditional cigarettes. Taking a tobacco history should be a key vital sign, just like we take people's blood pressure and pulse. So one of the first things that we want to do is ask our patients, do you use tobacco? And if they say yes, what forms of tobacco do you use? This allows us to get at dual use. Somebody uses smokeless tobacco and also vapes, or somebody that smokes traditional cigarettes and also smokes hookah. And asking specifically about the vaping and the e-cigarettes, particularly because people have this perception that they're less harmful, or they may not do it as often, so they don't necessarily label themselves as a regular smoker. We also want to ask how often you use tobacco, every day, but also every week, because if you are that college student that uses hookah on a Thursday night, and I ask you, how often do you use tobacco per day? You may say never, right? Hardly ever, because you only use it one day a week. So that allows us to capture both aspects. How long have you used tobacco? So ask someone what their age was when they first started. If the person is not currently using tobacco, so if you have a former tobacco user, make sure you assess their past history. Have you ever used tobacco, and when did you quit? This will give you a little bit more of an idea, first of all, of whether or not the patient is still experiencing effects of past tobacco use if they've recently quit, or how vulnerable they are to a relapse. When we obtain a tobacco history, it's like taking a medication history. We want more information about the dose. What's their smoking intensity? And this can be adapted to smokeless tobacco use. How many times per day do they use dip? How many cigarettes per day do they smoke? Do they smoke filtered cigarettes or non-smokered? Filtered cigarettes or non-filtered, rather. And when they smoke, do they smoke their cigarette all the way down to the very end? What some of the research has shown is that some people tend to have very light use. So they smoke a number of cigarettes, but they only take 1 or 2 puffs out of each one. People with disabilities tend to smoke more cigarettes and also smoke each cigarette all the way down to the end. Is there any additional use of tobacco products? Are they exposed to environmental smoke? And is there any forms of alternative or dual use, meaning that you have, again, somebody that smokes and also uses dip, or vice versa? We want to be able to talk to our patients about patterns of use. So when do they smoke in terms of timing? Do they smoke a lot when they first wake up in the morning, on their commute to and from work? What types of settings tend to trigger tobacco use? Are there any other people in their lives, significant others, family or friends who use tobacco use, who engage in tobacco use rather? And are there social situations where tobacco use plays a prominent role? These will all potentially can act as barriers to cessation, things that the patient has to be coached into recognizing and addressing when they come up with their action plan, their strategies for cessation. The other thing that we want to do is gauge the patient's level of dependence, and we can do this with a formal instrument called the Fagerstrom's questionnaire, which will be included in your course materials, but we can also do it with a single question. How soon after waking up do you smoke your first cigarette? And again, being able to adapt that. How soon after waking up do you take your first dip if you're using smokeless tobacco? And the sooner that the person smokes or uses dip, the more addicted they're likely to be, right? Because now they've been sleeping for 6, 7, 8 hours, been without tobacco for that length of time. When they wake up, they're already starting to experience symptoms of withdrawal. In order to calculate dose based on a pack year history, we need to remember that there are 20 cigarettes to a standard pack. And so often you'll hear like a certain number of pack years. 1 pack per day for 1 year would be 1 pack year. But like something like 10 cigarettes a day for 6 years, that's half a pack per day. So that would be a 3 pack year smoking history. This becomes a little challenging, and I often don't use this language in my own documentation, but in case you encounter it in the clinical setting, you'll be able to know what it means. So just a reminder to us that nicotine is in fact a drug. We don't write prescriptions for it generally, but it does have that impact on the body. So now you are dealing basically with somebody who has a drug addiction. So how do we assess nicotine addiction? We talked about that one important question: how soon after waking do you have your first dose of nicotine? Do you smoke a cigarette? Do you dip? Here's the Fagerstrom's questionnaire. So the Fagerstrom's test is a standardized outcome measure that's been developed and allows us to use a score. Anything greater than or equal to a 6 would indicate a high level of dependence. So look at the types of questions. There's that first one that we talked about, how soon after waking. But also, do you find it hard to refrain from smoking in places where it's forbidden? What cigarette would you hate to most give up? So the first morning one is the most challenging because of the period of forced abstinence while the person is sleeping. How many cigarettes a day do you smoke? Do you smoke more during the first hours after waking? Do you smoke if you're so ill that you can't get out of bed? And of course, these questions can be adapted. If you have somebody that doesn't use cigarettes but is using dip, then you can say, how soon after you wake up do you have your first dose of dip? Do you find it hard to refrain from dipping when it's inconvenient, etc.? So again, the most important question: how many minutes after you wake up do you have your first cigarette? Whether or not someone is successful in cessation will depend on the balance between their motivation to stop using tobacco and their degree of dependence. So let's take a look at that in graph form. If you have somebody with low dependence, but also low motivation to quit, they're unlikely to do so, even if they have adequate assistance. So when we're counseling somebody with low dependence and low motivation, our primary goal should be to activate the person's internal motivation to want to quit. And we can do that by discussing the relevance of tobacco use with regard to that person's goals. So if they're coming to physical therapy because they want to recover from a sports-related injury so they can pursue their normal activities, we can talk about delayed recovery and suboptimal recovery for that particular condition. If you have somebody with low dependence and high motivation, that's a pretty easy person to work with, right? That person is already working on it on their own most times, and we're just providing some external support. Patients with high dependence and low motivation are particularly difficult to work with. They are unlikely to stop. Our primary goal in counseling this patient is initially to increase their motivation. we're hoping to make them more receptive to even considering treatment for the dependence. High motivation and high dependence is also challenging. Even though the person is motivated, there's a physiological barrier now to quitting smoking or quitting tobacco use. So they're unlikely to be able to stop on their own, and this represents a majority of our remaining tobacco users. They know that it's harmful to them, they want to quit, but they're very, very nicotine dependent. So our primary goal then is to allow the person a greater awareness of treatment interventions, things that are available, things like nicotine replacement therapy that may help them with the addiction, with their dependence, so that they can activate that motivation and put it to work in actually being successful. Medications can assist by reducing withdrawal symptoms. Dosing is very important because you progressively want to taper down the amount of nicotine that the person has as they get closer and closer to full abstinence. However, nicotine replacement therapy cannot provide the motivation to quit. So remember again that there are two components, the motivation and the level of dependence. The nicotine replacement therapy addresses the level of dependence but doesn't necessarily make the person more motivated. Maximum benefits from treatment occur through a combination of counseling and nicotine replacement therapy. And our counseling approach should be tailored based on the patient's readiness to change. So let's review that just a little bit in terms of social and behavioral theory. So how do we assess readiness to change? This is when we talk about tailored cessation advice. It's tailored based on the person's readiness, like how receptive are they likely to be with regards to our advice. We know that when we do that personalization of the interventions, it increases the effectiveness of the counseling. So we can tailor that by asking the patient, how willing are you to give quitting a try? And very often we'll do this by asking the patient to rate their willingness to quit using tobacco on a scale from 0 to 10. So on a scale from 0 to 10, how willing are you to quit using tobacco right here, right now, in the moment? And so usually if the patient gives me a low number, like if I ask them on a scale from 0 to 10, and they say 3, well, that's not very high. So I say, okay, a 3, we want to avoid any kind of negative judgment. I don't say, oh, only a 3, but I say, okay, 3 out of 10. So what do you think it might take you to raise your level of motivation to, say, a 5 or a 6? And that gets us talking about some of the barriers that the patient might encounter. That's when the patient might tell you things like, it's really hard for me to quit because everyone at work smokes, or everyone in my household smokes, or I'd really love to quit, but the cravings become too much for me to handle, especially with all of the other stresses in my life, etc. So that gives us a little bit more insight on what the barriers are so that we can guide the person towards identifying strategies to overcome those obstacles. When we talk about readiness to change, what we're really doing is building off of the trans-theoretical model of behavior change that was developed by Prochaska. And you probably have talked about this when you talked about motivational interviewing. So if we look at a diagram of the stages of change, it looks very nice and neat, right? The patient progressively gets higher and higher in terms of their motivation to engage in behavior change, when in reality this tends to fluctuate. So if you look at the diagram on the left side of the slide here, it's sort of a circular path because sometimes we get stalled at a certain stage of change, or we may circle back. So we may go into the action phase and lose motivation or encounter obstacles that bring us back into the contemplation or pre-contemplation phase. So let's talk about these in a little bit more detail. Pre-contemplation, when we talk about the pre-contemplation stage, this is somebody that's not planning on any types of behavior change within the next 6 months. In the contemplation stage, the person is considering making a change within those next 6 months, but it's sort of nebulous. They're not real distinct in what it is that they want to change. They don't have a firm action plan or strategy in place. That changes in the preparation phase. In the preparation phase, it's more proximal. The person is ready to engage in behavior change within the next 30 days. So now they're beginning to formulate their action plan, put together strategies that might help them be successful. In the action stage, they're actually undergoing the behavior change, but it's been less than 6 months since the initiation. So they're relatively new at say, abstaining from tobacco use. And then hopefully we progress beyond action into the maintenance phase, where for more than 6 months you've successfully engaged in the new healthy habit. So what are the clinician's roles in terms of tobacco cessation? We said before that it's a tailored approach, and what that means is that our strategy towards counseling will change depending on our patient's readiness. In the pre-contemplation stage, the physical therapist's main role is to discuss topics that will elicit concern from the patient about their current behavior. So we are providing some information about how tobacco use or smoking will delay their recovery, may contribute to re-injury, etc. And it's very specific to the reason why the patient is seeking our help. So for instance, if someone comes to us and they're using tobacco and they're being treated for back pain, I can talk about the way that nicotine interferes with muscle strength and endurance, how it might inhibit the effectiveness of their pain medications and reducing their level of discomfort, and how it may compromise their long-term recovery. In the contemplation phase, the patient is thinking about making a behavioral change. So they're thinking about tobacco cessation, but they're still kind of weighing the pros and cons. So here our job is to kind of emphasize the positive. We want to make sure that the pros, the reasons for quitting, outweigh the potential drawbacks or obstacles that the person might face. So we really want to tip the scale in favor of quitting. So we acknowledge the fact that there are barriers or obstacles that exist, but also start to talk about ways that the patient might identify that would be suitable for them to overcome those barriers. In the preparation phase, our role becomes a little easier because we are really just acting as an expert or a resource to provide further information. And this really is the crux of brief counseling. We're not the ones going into any sort of detail. Hopefully we're eliciting the patient's motivation to quit and providing referrals in terms of information or other sources that the patient can consult with in order to gain support. So we might offer to contact the person's healthcare provider with regards to nicotine replacement therapy. We might have brochures available in the practice setting that provide information on group classes, or the quit line, which is the 800 number that people can call to speak to a quit coach and find out about local resources for cessation assistance. We'll talk about those in a little bit more detail as we move forward. In the action phase, you want to support ongoing change with encouragement. So this is our follow-up, right? We ask the patient how they're doing with their cessation attempt. That allows us to identify any new barriers that might come up. We can congratulate them on their short-term success and encourage them to continue building on that. Now, very often in the action phase, patients will have a lapse in behavior, and we'll talk about why it's important to distinguish between a lapse, which is just a momentary break in the habit. So, you know, you've quit smoking 3 weeks ago, and you go out with your friends and you have a cigarette after dinner. That is a lapse. It's not a relapse, which is a return to regular smoking behaviors. So we want to downplay that, but really use it as a learning opportunity. What tempted you to use the tobacco, and how do you overcome that in the future? In the maintenance phase, so if you have a patient that's quit smoking more than 6 months ago, you still need to congratulate them. You want to review the person's progress and reinforce their commitment to continue with abstinence. With a relapse, which is a return to the pattern of behavior, so not just that one cigarette after dinner one night, but now you're back to smoking several cigarettes a day over a period of a week or more than a few days. We want to emphasize the opportunity for learning and help the patient refocus their plans. And as we discussed before, tobacco use is a chronic condition, so a relapse is not unusual at all. It really is just another opportunity to learn about the challenges to cessation and rededicate yourself moving forward. So let's look at the clinical practice-based guidelines now for tobacco cessation counseling. As I mentioned before, they're based on the principles of motivational interviewing. And as you know, motivational interviewing is a client-centered approach to patient education for behavior change. So not only can it be used for things like tobacco cessation, but it can also be used to reduce alcohol use, promote exercise and physical activity, and things like proper nutrition and weight management. Probably the most important thing about motivational interviewing is that it is not centered on the practitioner at all. It's very patient-centered, meaning that we are asking the patient what's their goal and working from there. So it demonstrates the respect for the patient's independence and autonomy, which is really important especially when you're working with adults. None of us like to be told what to do. So we don't want to be overly directive. It's best that the motivation and the strategies for change come from the patient themselves. It's associated with greater patient satisfaction with healthcare. So again, that addresses that anticipated resistance that all of us have towards addressing personal behaviors with our patients. When we talk about personal behaviors, it's seen as a component of holistic care. So the patients actually think more of us when we talk about these issues. They perceive us as a very caring individual. And it may have the most benefit for patients that are initially resistant to change. The main goals of tobacco cessation counseling within the context of physical therapy practice is that we are trying to change the patient's perceptions about the usefulness of tobacco use as a coping method. So we mentioned before that there are physiological reasons for this. Tobacco use is associated with some of these feel-good hormones, things like dopamine, serotonin. So in the short run, tobacco use may actually be a way of coping with stress, but in the long run, it creates more stress than it's worth. So we want to help our patients to identify and implement alternative methods for coping. And perhaps most importantly, we want to build their confidence in their ability to quit. Don't forget that people who have smoked for a long period of time or have used alternative forms of tobacco for a long period of time have probably tried to quit on their own. Number one, they're aware that it's harmful to them. And number two, because they're aware that it's harmful to them, they have likely tried to quit before on their own and have been unsuccessful. So especially if that occurs multiple times, it erodes the person's confidence in their ability to quit. And this is perhaps the biggest obstacle to behavior change associated with tobacco. They've tried to change in the past and they've failed, so now they have this fear of failure combined with reduced self-efficacy, reduced confidence in their ability to successfully engage in cessation. The general principles of motivational interviewing can be summarized using the acronym ORS. And ORS stands for open-ended questions, which is how we get at the information that we're seeking from the patient. Affirmations that show the patient that we're really listening. Reflective listening, which allows opportunity for clarification and furthers the conversation. And summarization. So we'll talk about each of these in a little bit more detail. The benefits of the motivational interviewing approach are that, number one, they are tailored, as we mentioned. So it recognizes that there are differences among the patient's reasons for tobacco use and the patient's readiness for change. It explores the patient's perspectives regarding the costs and benefits of cessation. Another way of saying this is the challenges and rewards. And we can do this with the open-ended questions. What do you see as some of the biggest obstacles that you might face now that you're considering quitting using tobacco? It explores the ambivalence between the patient's own values and their current behavior. It's clear that your patient values their health or they wouldn't be seeking physical therapy intervention, right? If you had somebody that didn't really care about themselves, they probably wouldn't put the time and effort and the expense that's required in order to have physical therapy treatment. So we want to build on that. If your goal is to become well again and to have successful rehabilitation with PT, then let's talk about how tobacco use can get in the way of those goals. So let's look specifically at the use of motivational interviewing for tobacco cessation. First of all, we want to express empathy. We recognize that tobacco is a highly addictive substance. It is very, very difficult to quit. And by expressing empathy, by acknowledging how hard it is to quit, we are seeking to understand the patient's perspective. So it allows the patient to know that we're receptive to their input. We're not making any types of negative judgments. We're not coming across as condemning the patient's tobacco use, but we're exercising a genuine curiosity in the patient's reasons for using tobacco, what their concerns might be about quitting, and not only the obstacles, but their perceived benefits. Sometimes I'll ask patients, what's the best thing that you can imagine happening if you were able to successfully quit? Don't worry right now about how the quitting will happen, but imagine that I'm able to wave a magic wand and make you a former tobacco user right now. What are some of the best things that might come out of that? So rather than focusing only on the adverse effects, now we're having the patient imagine or project some of the benefits. And again, we're developing that cognitive dissonance. We're hopefully tipping the scales in favor of the decision to quit. As we're expressing empathy, we're using reflective listening to ensure our level of understanding. And this can be a little bit challenging. When I first learned motivational interviewing, I was kind of like a bad parrot. So the patient would say something like, I really want to quit smoking. And I would say, oh, so quitting smoking is really important to you? And you can imagine just how aggravating that actually is for somebody. So instead of just parroting back, we sort of infer the hidden meaning behind what the person is saying and kind of hope to further the conversation. And sometimes we find out that we're not on the right track. I make assumptions that are not necessarily true, and it allows the patient to clarify. So an example of this might be restating the patient's concerns about quitting. So from what I understand, you feel that smoking helps you maintain your weight. Is that correct? So this might be somebody who says something like, I'd quit, but then I'd get fat, and being overweight is not healthy for you either, and that's not going to help my back. So that allows us to get a little bit more information on what it might be that's forming that obstacle so that we can address that with further information. Reflective listening also allows us to provide that summary. So you understand the health risks of using dip, but you're afraid you will not be able to manage your stress well if you quit. So that kind of furthers the conversation as well. First of all, it gets at the patient's primary reason for continuing to use because they're using it as a coping mechanism, and it allows us to talk about other mechanisms for reducing stress. Number 2 is developing discrepancy. Again, we want to highlight the difference between the patient's values and goals and their current behavior. So the mismatch between tobacco use and expressed values. For instance, we might say something like, you sound like you're very devoted to your children and you're concerned for their well-being. How do you think they're affected by your tobacco use? Now stop here for a minute, because if you look at the way this is phrased, this is a lot different from me coming in with a judgmental attitude and saying, don't you know that smoking is harmful to your kids? That's why your baby has so many ear infections, because you smoke. So right away, there's a very negative tone to that will probably cause the patient to become defensive, and as any of us would be if somebody challenged our behavior and intelligence in that way. So instead, find something positive about it. The person's very devoted to their children, and let them make the connection for themselves. How do you think they're affected by your smoking? We might say something like, you've been working really hard to get yourself in better physical shape, but it sounds like you already see how smoking is affecting your endurance. How do you think your workouts would change if you were able to quit? Again, we're asking the patient to imagine the benefits of quitting rather than focusing on the negative impacts. We want to also support the patient's commitment to change. It sounds as though you already realize how tobacco use is affecting your health and you'd like to quit, but you feel unprepared. Would it be okay for us to help you in finding additional resources? If you'd like, I can call your doctor to make arrangements for you to discuss medications that can help with the withdrawal symptoms. How does that sound? Now, the big thing here is that we're asking permission, right? So we're respecting the patient's autonomy, their right to choose, because sometimes people aren't ready to talk about this right now. If I get you on a bad day, if you're a patient and you come in and you're having intense pain in your back, now is not the time, perhaps, for us to be talking about tobacco cessation. On the other hand, it might be a teachable moment. You have such intense pain and you notice that the pain medication isn't working for you. What else can you do? Well, that might be my opening to start talking about tobacco cessation with you. So again, it's very individualized, but you're allowing the patient to tell you what's going on in the here and now, what's going on in their personal life outside of the clinic, and is this a good time to talk about this, or would they prefer to postpone the discussion to a later date? And that also gets us past the anticipated resistance, because if I give the patient a choice and they don't want to talk about tobacco cessation, well then that's the opportunity for them to tell me that and for me to be able to respect that. And depending on how receptive they are, I may say, would it be okay if we table the discussion and maybe talk about it at the next visit? And they may say yes, and then at the next visit you bring it up again. Either they're receptive or they're still not receptive. The big thing is that we're not forcing our values and our goals for tobacco cessation on the patient. We're allowing them to decide how much they want to hear and when they want to hear it. Number 3 goes right along with that. We're told that we should roll with resistance, right? Any type of health behavior change is going to come with some level of resistance. In general, we don't like change, even when it's change for the better. And we don't like being told what to do, so we're trying to avoid that. And it's very common that the person's going to come up with reasons why they can't quit, right? We want that to happen to a certain degree. That's not what we'll place the emphasis on. We're trying to highlight the positives, the advantages of quitting. But when that resistance comes, we accept it. It's just a normal part of the process. We can acknowledge that the patient may feel pressured. So if you are fearful of patient resistance, or you think that you might destroy your rapport with the patient, it is somewhat delicate, right? If the person becomes resistant, you can acknowledge that. Listen, it wasn't my intention to badger you or pressure you in any way. I hope that's not how it came across. Really, you're the only one that can make the decision to quit, and you'll let me know how much information or how I can assist you as we go along. Acknowledge that quitting using tobacco is a very difficult decision. Also, a lot of people need time to consider the challenges. Let the patient know that you're willing to listen and that we can assist them in identifying some better strategies when they're ready. Always ask permission to provide information. So if I'm going to give somebody a brochure, I just don't throw it at them or force them to take it with them. I ask. I tell them I have some written information that you can take home with you. Would you like me to get that for you? The other thing that I want to mention here is that it's often helpful to have those brochures or posters or flyers of some sort out in the waiting room. What that does is it tells the patient that that's something that's important to us, because very often they're not anticipating the physical therapist to talk about tobacco cessation with them. It may not seem relevant to the reason why they're coming to us for treatment. If we place those things where they're highly visible out in the waiting room, then it lets the patients know that that's on the table. Tobacco use is something that concerns us, and we'd like to work with you towards your success. We're supporting self-efficacy. So this is true in all aspects of physical therapy. We value patient independence, and we try to make that, we try to emphasize that whenever possible. Remember that many of our patients are discouraged because they've tried before to quit using tobacco and they've been unsuccessful. So, if somebody tells you that they've tried 4 or 5 times before to quit and they just haven't been successful, and they say, I just can't quit. I've tried 5, 6 times before and I really haven't been able to be successful in the long term. Sometimes I'll ask them, 5 or 6 times, first of all, that means that it's something really important to you. If you're that dedicated that you're willing to try and try again, then it means that it's something that's really important, and maybe you just haven't hit on the right combination of strategies to ensure your success. But you have found out what didn't work, right? So let's talk about that a little bit, if that's okay. What's the longest that you've gone without using tobacco? And sometimes people will tell you several months, and that gives you an opportunity to congratulate them. Wow, you quit smoking for 3 months? That's a really long time. Did you know that most of the time the physical aspects of withdrawal subside within a month? So you actually got past the hardest part. What did you learn from that? What made it more challenging to continue past that 1 month period? That's where you get sometimes into the environmental obstacles or barriers that the person might be experiencing. So we want to, first of all, get at what has contributed to the lack of long-term success so that we can address those moving forward. But we also want to start building confidence by having the patient make a series of small goals. And sometimes it's as simple as asking the patient to call the quit line for advice and information. So, it sounds like maybe you've had difficulty identifying a strategy that works for you. Maybe if you call the quit line and talk to that person, they might have suggestions. How does that sound as a first step? Do you think that, you might be able to call the quit line within the next few days? You can also give them reading materials about strategies for cessation, because that allows them to take it in on their own time in their own territory. We can build confidence in unrelated ways. You can help the patient establish an exercise program. And some of the research has suggested that if you're successful in one aspect of behavior change, like becoming more physically active, then it builds your confidence to be successful in other aspects of behavior change, like tobacco cessation. The other thing is that if you're doing something positive for your health, like exercising or eating well, the next natural step is to extend that to other things that could potentially damage or interfere with those goals, like tobacco use. If you're going through all the trouble of eating well and exercising, then tobacco cessation is the next logical step. The other thing is that the patient can start to imagine what's the advantages of cessation. So maybe encourage them to start a personalized list of potential benefits of cessation. There are some, as I mentioned earlier, common barriers or obstacles that are commonly cited by people as challenges towards cessation. So we want to be able to offer information that can help them see how that challenge might be overcome. Very often patients will have concerns about weight gain. The research has shown that actually the average amount of weight that's gained by somebody during a cessation attempt is only 7 to 10 pounds. So, that sounds like a lot for some people, but 7 to 10 pounds of weight gain is a lot healthier than continuing to use tobacco. And second of all, that's not mandated. It's not absolutely definite that you'll gain 10 pounds. We can talk about strategies to reduce the likelihood of weight gain, things like eating a balanced diet, exercising, drinking more water. Many patients have concerns about withdrawal symptoms. First of all, we can assure them that that is a temporary condition. It typically peaks within a week and at most 3 to 4 weeks post-cessation. And there are strategies to address withdrawal symptoms as well, including the nicotine replacement therapy and other coping techniques. Fear of failure is actually the most prominent barrier to tobacco cessation. As we mentioned before, people are well aware that tobacco use challenges their health, and most patients want to quit. So most people that use tobacco actually want to quit, but they're afraid because they've tried to quit before on their own and they haven't been successful. So it's important to express empathy, but to emphasize that half of all smokers are eventually successful. So 1 in 2 people that try to quit are eventually successful in their attempt. Repeated attempts at cessation actually enhance the likelihood of success. So if you've tried to quit 4 or 5 times before, well, it takes an average of 9 times. So you're that much closer to success. In addition, the longer a smoker's cumulative abstinence, meaning that if you quit one time for 2 weeks and then the next time you last a month, well, together you've been abstinent for 6 weeks, that increases your likelihood of long-term success as well. So this is just a reminder that half of adult smokers have quit, so you can too. Let's look specifically at the guidelines themselves. Very often these are summarized as the 5 A's and the 5 R's. So the 5 A's are used when you have a patient that's receptive to quitting. So this is somebody that's in the contemplation phase, or they're actually in the preparation phase, and they're willing to consider making the attempt. So each of the A's stands for a different step. The first A is for ask, and that refers to screening for tobacco use, but also the level of nicotine dependence. Advise is when we provide information on why and how cessation will improve their physical therapy outcomes. And again, the relevance of it, making very specific with regards to the patient's reason for seeking our assistance as physical therapists. The third A stands for assess, and that's where we look at the patient's readiness to change. So how willing are they to quit? And we also start to talk about some of the potential barriers, but also some of the assets or facilitators that would promote their successful cessation. In the fourth stage, which stands for assist, we might be providing patient education materials and referral sources. So really, this is the primary goal of brief tobacco cessation counseling. We're eliciting motivation to quit, and then we're providing referral sources that support the patient's cessation attempt. The fifth one stands for a range, and it's really important that we follow up with our patients. First of all, we can provide continued encouragement, and we can help the patient prevent having a lapse become a relapse. And we can also encourage them to be rededicated towards cessation if they have had a relapse. So just as a brief review, asking at the initial encounter, we're obtaining the tobacco use history, and we might consider the use of the Fagerstrom's questionnaire in order to gauge the patient's level of addiction. Now, even though we might ask the patient when we first see them, so during their initial evaluation, take their history and ask about tobacco use, it's usually not at that initial encounter where we will do the counseling unless you're only going to see the patient once or twice. The reason for this is that the counseling becomes more effective when you've already developed a relationship or rapport with that individual. Advise, we do that once the therapeutic alliance has been formed. So as you develop that rapport, you get to know the individual a little bit better. But we do want to do that early on in the episode of care so that we can reinforce it as necessary as we move forward. Our advice should be clear, okay? So there should be no ambiguity to it. Oh, I really think it might be helpful if you quit smoking. No, quitting smoking is one of the most important things you can do for your recovery. So it's clear, it's strong, but it's also personalized to the patient's PT diagnosis. So if I have somebody with a shoulder injury, I'm talking about the benefits of tobacco cessation with regard to their recovery. If I'm talking about to somebody with an open wound, I will give advice that's specific to the ways that nicotine impairs the healing of the skin. Always tie it into the reason why the person is coming to see you. Strategies for providing advice. When we say clear, it's very important. Strong, it's the most important thing, and personalized. It'll improve your rate of wound healing. People that stop using tobacco tend to get better results in decreasing their pain. Nicotine can interfere with bone growth. If you quit using tobacco now, you'll be less likely to experience complications from your spinal surgery. Assessing, there's where we use the open-ended questions. We get the patient to tell us how willing they are to quit right now. And so that's where we might use that 0 to 10 scale and gain more information by asking them what it might take to move them into the higher numbers. In assisting, if your patient is ready to quit within the next 30 days, we provide recommendations that would support them through the action phase. If they're not yet ready to quit within the next 30 days, then we're going to proceed with the 5 R's. Keep in mind that even if a patient is not immediately willing to quit smoking, practitioner advice will increase the motivation for a future attempt. I can't tell you the number of times that this has happened to me. So at first when I started doing this, I didn't think I was very successful at all, because if I'm seeing a patient for 4 weeks, 6 weeks, 8 weeks, very often during that 8-week period, the patient's not going to quit smoking or quit using other forms of tobacco. But I've had people see me later on at like a social event or out in the neighborhood and say, "Hey, remember me? I saw you for my back pain back in October or whenever. And you were telling me how tobacco use affects the muscles in my back, and I was finally able to quit." And they're all proud of themselves, and gives you a chance to congratulate them and see the long-term outcomes of your counseling. Or sometimes it's the doctor or other healthcare practitioner that tells us, "Hey, you saw my patient after the total knee replacement, and they told me that you spoke to them about tobacco cessation, and they were finally able to quit." So keep in mind that sometimes we don't get to see the fruits of our labor, but they're there. So in the action phase, when the patient reports that he or she is willing to quit within the next 30 days, we commend them on their willingness to quit. We express empathy that they've been able to make such a difficult decision, and then we provide those supplementary materials. We can also offer to contact the person's healthcare provider if they're interested in nicotine replacement therapy. In some states, The class action lawsuit has actually provided funding for free nicotine replacement therapy. So I know here in Florida, if the person goes through the Department of Health Area Health Education Center for group counseling, they get 8 weeks of free nicotine replacement therapy. So there may be similar programs in your area. That might be something important for you to know. During the action phase, in preparation for quitting, we're encouraging our patient to take a starring role. So I know there's lots of acronyms. ORS, we talked about the 5 A's. Now we're talking about STAR as an acronym. It just kind of helps us remember the procedure. STAR stands for setting a quit date, and ideally their quit date should be within 2 weeks of approaching the subject with them. So if the patient tells me that they're willing to quit, then I say, when's a good date for that to start? The T stands for telling family and friends, so enlisting social support. And this sometimes is a little bit tricky. If you have somebody that's tried to quit a number of times before, maybe their family and friends, they're getting a little impatient with them. So you have to trust the patient's judgment of whether or not they think it might be helpful to tell their family and friends. And if they can't tell their family and friends, well, can they use an online support group or an in-person support group to provide that additional understanding for them and encouragement. A stands for anticipating challenges, and by anticipating challenges or barriers, we're better able to identify strategies to overcome those obstacles. R stands for removing tobacco products from the environment, so the person should be encouraged to create a tobacco-free home and workspace. When the person sets the quit date, as I mentioned, it should ideally be within 2 weeks from the initial commitment to quit. If possible, you want them to plan for a time that's not stressful. So for females, this might include like the menstrual cycle. You obviously don't want to try to set your quit date when you are expecting to have PMS and cramps, etc. If it's around the holiday time and you have in-laws visiting, it might not be a good time to start using different coping mechanisms to reduce your stress. So the patient will be able to tell you themselves what the best time might be, but we don't want to put it off too long. Intermediate steps: if you have somebody that's not willing to quit within the next couple of weeks, we might have them consider something called a scheduled reduction. And this actually has proven to be really, really successful in terms of some of the research on tobacco cessation. Scheduled reduction involves decreasing the number of cigarettes or the number of doses if you have somebody that's using smokeless tobacco. So how many times per day are they using tobacco? So ideally we should be decreasing the number of doses and lengthening the time in between doses. This may act almost like a nicotine replacement therapy in that it's gradually reducing the person's dependence and withdrawal. And it also builds confidence, because if you're able to go more than an hour without a dose of nicotine, can you go 2 hours? Can you go 3? Can you go a whole day? And as a person gradually builds on that success, they become more and more trusting in their ability for long-range cessation. Other intermediate steps involve limiting the smoking environment or the setting. So the person that's using tobacco chooses only 1 or 2 locations where they allow that to happen. And ideally that should be a very unpleasant location. I had a group of individuals. I was treating a few mechanics that worked at a tire company. And it just so happened that due to the nature of their job, they had a lot of occupational related injuries to their shoulders, their neck, and their back, lots of orthopedic conditions. And one of them expressed a willingness to quit using tobacco. Smoking and using dip was very, very prevalent within the shop that they worked in. Everybody basically was doing it. And so once that first individual made the commitment to quit, we decided, or he actually decided, that he was going to enlist the assistance of his coworkers. And because so many of them were experiencing similar health problems, it actually became really important to them. Once they saw the relevance of tobacco cessation with reference to becoming more healthy and better able to engage in their jobs with less pain, then they were more motivated to carry forward their strategies to reduce the challenges. And because they were all trying to quit at the same time, they did have that social support. But one of the strategies that they actually came up with is that if you wanted to smoke, you could smoke at work, but you had to do it out by the dumpster on a folding chair. And this was in West Virginia, and it was cold. So you were cold and uncomfortable while you were supposedly enjoying your cigarette. So reducing some of the pleasure cues that come along with the tobacco use was really important to their success. So limiting the location where the tobacco use is permitted, ideally choosing an unpleasant location which gradually breaks those environmental cues. The focus, even with these intermediate steps, is for the patient to achieve complete long-term abstinence from tobacco. Arrange, it's when we do our follow-up. So ideally that might occur at the next visit. So if you're seeing somebody for 2 to 3 times a week for 4 to 6 weeks, well, we have plenty of opportunity for follow-up. But we do want to arrange that with the patient. I may say, would it be okay for me to check in with you at the next visit to see how you're doing with your cessation attempt? Because that primes a person. It lets them know that we care and that they probably are going to hear more about our interest in their tobacco cessation at their next visit. Or if you need to do telephone follow-up, you don't want to be like a bad telemarketer that calls in the middle of dinner. So you actually schedule a phone call by asking the patient when it might be most convenient to reach them. It's best to initiate your contact within a week of their quit attempt. So if I know that somebody set their quit attempt for this Friday, by next Friday I want to set a time and a date where I can speak with them to see how they're doing with that. If there's any new unanticipated challenges or changes in strategies that might be necessary, or if the patient's doing well, use that as an opportunity to congratulate them. So the first follow-up should be within a week, and the second follow-up should be within a month. Strategies, again, we want to identify any problems that they've encountered and help them to find a solution or additional resources. Congratulate the people that have been able to maintain abstinence successfully, and if the person has relapsed, help them renew their commitment to total abstinence by reviewing the circumstances. So what led to the relapse and how in the future can that be avoided? Methods, the office visit, the phone calls. I've even used text messages, and some of the research has suggested that emails can be effective. And some of the research uses group text and group emails, but we talked about how important it is to individualize your approach. So I like to personalize it and be able to use the patient's name and ask them specifically about things that we've discussed in our past sessions. In the contemplation phase, these are patients that are not ready to quit yet. We want to acknowledge the difficulty in making such a tough decision by saying something like, that's okay. Most people who use tobacco aren't ready to quit right away. I'd like you to give it more thought if you would. Remember that you're the only one that can decide to quit smoking, but I'm willing to help you in any way I can. So that takes the edge off by not applying pressure to the person, reinforcing the fact that we are not mandating that they quit. We're not prescribing cessation in any way. We are encouraging it because we're concerned about the way that it affects their PT outcomes and their overall health. So for patients that aren't willing to quit right away, we're going to follow the guidelines known as the 5 R's. 5 R's stand for relevance, risks, rewards, roadblocks, and repetition. So let's look at each of these steps individually. Relevance has to do with the ways in which tobacco use or smoking affects the individual's immediate health. So examples are those physiological effects that we talked about before, and picking the ones that are most relevant to the person's PT diagnosis. So examples, tobacco use interferes with bone healing. It may increase the likelihood and intensity of pain. It contributes to impaired muscle strength. It can delay tendon healing. Pick the ones that are most likely to resonate with your particular patient. Risks. Sometimes the risks that are relevant to the patient are not immediately evident to us. So it's best to ask an open-ended question, something like, what do you think are some of the dangers that you face as a result of your tobacco use? So you're asking the patient to consider the negative consequences, and both in the acute phase and in long term. So sometimes patients, especially younger patients, will say, well, when I get older, I'm going to get lung cancer. And I might say something like, yeah, research has shown that is true. But what about now? You're 18 years old. I don't know that you're spending a lot of time thinking about what's going to happen when you're 65. As an 18-year-old, can you think of any potential risks that you might face right now as a result of your tobacco use? We can also talk about the impact of secondhand smoke if they are using cigarettes. So what's the impact of secondhand smoke on their children and other family members, and even their pets? I'm surprised, and again, I should avoid negative judgment, but I've been surprised by the number of patients who are more concerned with their cats or dogs than they are with their loved ones. So most people know that secondhand smoke has a negative impact on the people around us. But people are often surprised when I tell them that it can cause health problems in their dogs or cats. So you use whatever works. If the perceived risk to the dog is the most important thing motivating a person, we're not judging. We're using that to further their success. Rewards, we're talking about with our patients, allowing them to identify the benefits of cessation. So what's the best thing you can imagine if you were able to successfully quit smoking? Better health, improved physical function. Sometimes we ask questions like, what would you do if I might ask them something like, how much money do you think you spend in a month on tobacco products? And what would you do with all that money if you were able to quit? Sometimes people are motivated by cosmetic appearance. So you can have whiter teeth. There's less likelihood of wrinkling and signs of aging in people that quit smoking. Immediate benefits. So we want both short-term and long-range benefits. Foods will taste better. Your clothes, your home, your car, and your breath will smell better. And you're setting a good example for other people. Roadblocks. This stands for the perceived barriers. So being able to address some of those common obstacles, things like weight gain, fear of withdrawal, and the ability to cope with stress. Repetition. Now, we're not beating people over the head with this, but we do want to check back with them to see if anything has changed with regard to their motivation. So we want to raise the subject every once in a while, and again, asking the patient permission to do that. So we're continuing to assess the patient's willingness to quit and reminding the patient that most people will require multiple attempts before they succeed at long-term cessation. Managing lapses and relapses. Remember that there is a distinction between a lapse and a relapse. A lapse being a brief instance of tobacco use, and a relapse being a return to a regular pattern of tobacco use. So successful cessation is a process, and it normally requires many attempts before the person is successful in long-term abstinence. And our primary goal for follow-up is to learn from those lapses and prevent relapses. Recommended systems change. We said that really this is an effort that involves everybody in a practice setting. So starting with administration and the clinicians, right down to our support staff. And the support staff can assist with provider reminder systems, things like placing stickers on charts if you're still using paper records, or computer prompts for electronic health records. Using documentation templates that incorporate things like the Fagerstrom's questionnaire or tobacco use history to kind of remind us that that's important during the initial evaluation. Using uniform screening methods streamlines communication among providers, and then making sure that all clinicians are consistent in their message, that it's important that the patients who use tobacco quit to enhance their likelihood of positive outcomes from physical therapy. Other potential facilitators that allow us to successfully engage in tobacco cessation counseling would include things like provider incentives. So sometimes a managed care company will provide incentives to providers who incorporate tobacco cessation counseling as a component of care. Patient incentives for successful cessation, and you'd be surprised, even little things like a free t-shirt or a free hat. And then using tobacco cessation counseling as a measure of patient care quality, because we do recognize the positive impact it has on outcomes. Other potential facilitators, if you have a dedicated staff member that's trained specifically to provide tobacco cessation counseling, this often can get past the barriers in the providers themselves. Sometimes people don't feel confident in talking about this, or they lack training. So if there's somebody willing on the staff who is really good at this, sometimes we can have them come in for a consult. Again, having that visible literature in the waiting room and exam rooms, letting the patient know that this is a topic that we're involved in and something that we're interested in and will likely come up during the course of their treatment. And obviously adequate insurance reimbursement for the services that we provide. PT advocacy, so we should be involved outside of the clinic in other efforts to promote reduction in tobacco use, so indoor air legislation, tobacco-free campus initiatives, etc. Promoting tobacco-free social norms. So it's not something that's acceptable for people to use tobacco. That can reduce the initiation, of particularly among young people. Promoting the quit lines, regardless of where you're at in the United States, there's an 800 number that your patient can call that would direct them to local resources, and it's very easy to remember. It's 1-800-QUIT-NOW. So regardless of where you're practicing, you can at the very least give the patient that 800 number. That will connect them with a quit coach, and that quit coach can actually do some of the steps involved in the counseling and point the person towards some local resources. Eliminate barriers to access services, particularly among people with disabilities, and take a strong leadership role. So additional resources, again, because we're doing brief counseling and hopefully making the patient recognize that they are motivated to quit and have some resources and strategies available for them. One of the things that we might talk about are the benefits of physical activity. So as an adjunct to cessation, we know that exercise helps to stimulate endorphin release, and that can mitigate withdrawal symptoms or act as a replacement activity for tobacco use. Engaging in physical activity shows that the person's dedicated towards their health, and it may increase their confidence towards successful tobacco cessation. It can assist in controlling weight gain. It can decrease insomnia that's associated with those withdrawal symptoms. And again, it can act as a diversion. So as PTs, we're very comfortable with recommending exercise, hopefully. So this can act as a resource or a referral source for people that are trying to quit. Nicotine replacement therapy, it's very effective and should be used at every instance except when contraindicated. So it's very important that we don't do this as a standalone. We're not prescribing nicotine replacement therapy. Remember that nicotine is a drug. So we want to do this in consultation with the person's primary health care provider, because that person, the primary health care provider, will know whether or not there are other medical conditions that need to be taken into account or other possible medication interactions. Nicotine replacement therapy can reduce, but it does not completely eliminate withdrawal symptoms. So it should be used in conjunction with other strategies, and it's important to make sure that the person has reasonable expectations going in. There will be some associated discomfort, but this should probably take the edge off for them. Again, the nicotine replacement therapy requires interprofessional collaboration, and some of the benefits, if you look at the statistics that are derived from the research, the use of medication alone increases the likelihood of cessation about 21%. The combination of medication and counseling increases the likelihood of successful long-range abstinence by about 26%. So that's pretty impressive. Types of nicotine replacement therapy. There are over-the-counter and non-prescription nicotine replacement, such as the transdermal or skin patches, nicotine gum, and nicotine lozenges. There are also prescription products like a nicotine nasal spray or a nicotine inhaler. Other types of pharmacotherapy, there's something called bupropion, which is the generic name for Zyban. Other brand names include Wellbutrin or bupropion SR. This type of medication mimics the effects of dopamine and norepinephrine. The caveat here is that if the patient's setting a quit date, they have to begin the bupropion about 1 to 2 weeks before, because it takes a while for a therapeutic level to build up in the patient's system. The duration of therapy with bupropion is usually 7 to 12 weeks. Chantix, I can never pronounce the name of the generic, so you see it right there. But Chantix works by blocking nicotine receptors in the central nervous system while still allowing the release of dopamine. So you don't get any pleasurable effects from the tobacco product, but you're still getting the pleasurable effects from the medication itself. Here, there's a 1 week lead time, so it takes about a week to build up therapeutic levels. So the patient should start the Chantix about a week before their quit date. The duration of therapy for Chantix is a little bit longer than for bupropion, and it's usually about 12 to 24 weeks. And really, this is tailored based on the patient's success rate and how long it's taking them to completely quit. Clonidine is a medication that's usually used for the treatment of high blood pressure. It's thought that it might assist in controlling withdrawal symptoms. Obviously, it's only by prescription, and because of the potential impact on vasodynamics and blood pressure, it's again important to be monitored by the healthcare provider, the physician, and when the person stops taking the clonidine, it requires a tapered dose. Nortriptyline is an antidepressant that is sometimes used as a second-line pharmacotherapy for tobacco cessation. It has demonstrated efficacy that's equivalent to nicotine replacement therapy. It has a pretty long lead time, so the person has to start taking the nortriptyline about 1 month prior to their quit date. Nicotine patches, the way that they're used is that the patient should start using them as soon as they wake up on their quit date. They should be applied to the skin between the neck and the waist. In order to apply it properly, you should clean the area with soap and water. You want to avoid areas of excess body hair, and the site should be rotated every 24 hours to avoid topical skin irritation. Typically, the dose should be tapered over time so that you're becoming fully abstinent from nicotine. In general, the dose is tapered in increments of 7 milligrams. So for the first month or so, the person uses 21 milligrams, and then in the next 2 weeks, so from week 4 to 6, 14 milligrams, and from week 6 to 8, 7 milligrams. Again, make sure, even though these are available over the counter, that your patient is discussing this with their primary health care provider, because we want to avoid any interactions with other medical conditions or medications that the patient might be taking. Nicotine gum sometimes works well for patients that have been using dip or other oral forms of tobacco. They should use the gum on a fixed schedule, at least 1 piece every 1 to 2 hours. They continue the use of the nicotine gum for approximately 1 to 3 months. The maximum dose is no more than 24 pieces in a day. And like the nicotine patch, it has a controlled dose. So 2 milligrams of a dose if the person smokes less than 25 cigarettes a day, and 4 milligrams if they smoked more than 25 cigarettes a day. Remember that there's 20 cigarettes to a pack. The way that the nicotine gum is used is that it's chewed and then parked. What they call parked is what that means is that they chew the gum a little bit to release the nicotine, and then they push the gum up in between their lip and their gum, very similar to how you would use snus or dip. And they park it there for about 30 minutes until the taste is completely gone. When the person is using nicotine gum, they should avoid eating or drinking for 15 minutes before the dose or while they're chewing the gum. And again, a reminder to consult their healthcare provider. So in addition to the prescription medications and the nicotine replacement therapy, I also want you to consider some other potential harm reduction strategies. We discussed how the electronic cigarettes, the vaping, is not really a viable option. It is a nicotine delivery system, but there's no research to support the claims that this assists with cessation. The other harm reduction strategy that's sometimes marketed actually as a way of quitting smoking is the use of chew or smokeless tobacco. Keep in mind that smokeless tobacco is just as harmful as cigarettes in many respects. It's been associated with oral cancer, cancer of the GI tract, other types of ill health effects, and it still contains the nicotine. And again, there's no research to support the claim that it assists in tobacco cessation in any way. More commonly, what happens is that the use of smokeless tobacco in addition to cigarettes contributes to something called dual use. So now instead of just smoking, you have a patient that uses cigarettes and smokeless tobacco, so they're getting even more nicotine than they were before. Remember that alternative forms of tobacco may delay or discourage a full quit attempt. So because it's not supported by the evidence, this is not really something that we want to promote within our patients. Complementary and alternative medicine, admittedly, I don't have a huge amount of experience in this. I've had some patients that have successfully used things like laser therapy and acupuncture to assist in their cessation attempts, but I can't provide any evidence that supports that. So more research is required. Options include things like hypnosis, meditation, and guided imagery. I mentioned the acupuncture and the laser acupuncture. Yoga, which might work as a coping strategy, help reduce stress. Massage, again, as a stress and coping mechanism. Acupressure, the use of certain herbal supplements and nutritional supplements, and aromatherapy. So here's some additional resources for referral, and these are publicly available. So if you have a patient that wants to seek some of this out on their own, we can refer them to the U.S. Surgeon General's website, the National Quit line that I mentioned before, 1-800-QUIT-NOW, and the American Lung Association has a program called Freedom from Smoking, and it's entirely online. So if you have somebody that's not able to go to group classes or things like that, this might be a viable alternative for them. Other public resources, the American Cancer Society, the American Legacy Foundation. You might be familiar with them because of the Truth campaign that you see on television every once in a while. The CDC Collaborative Government website, and there's a StopSmokingCenter.net that has an online support group as well. Here's my contact information, so I look forward to hearing from you. I am a full-time faculty member at Adventist University of Health Sciences in Orlando, Florida, and there is my email address. So we'll be scheduling a live session, distance obviously, although I wish I was coming out to Montana to see you in person, and we'll be providing materials for you with the case studies for tobacco cessation counseling. The case studies, again, being drawn from clinical practice based on readiness to change and common obstacles or barriers that are encountered. And with those case studies, you'll be using an observation checklist to provide peer feedback to one another, and we'll be discussing that a little bit more when we actually meet. So please do contact me if you have any types of questions, comments, or feedback, and I look forward to working with you. Thanks so much.